Welcome to the Special Operations Medical Association podcast series on prolonged field care. Any opinions contained in these podcasts are those of the authors alone and do not reflect U.S. Army, DoD, or U.S. government opinion or policy.
Welcome back to the Prolonged Field Care Podcast. This episode was recorded live at the 2016 Special Operations Medical and Scientific Assembly. It was directly paid for by SOMSA and was part of our pre-conference lab. This was one of the small stations that Justin set up, and he had a couple of his special guests come in and talk about different ketamine and pharmacological strategies for managing pain. I hope you enjoy it.
So I can say, having worked on the working group for about 2 years, is all the drug knowledge is by far the subject that's been talked about the most. Everybody, all the questions that come in, a lot of it is related to ketamine and all this drug stuff. And I think you guys can see that the theme of this pre-conference has been ketamine use. So what we want to do, in the spirit of Scott Weingard and the EM Crit podcast that he put out, he talked about why he did his podcast, and the whole point is logistics, actually doing this stuff in the field. And I've noticed that when I get new medics in and I hand them 500 milligrams, a 500 milligram vial of ketamine, and it's 100 milligrams per ml, and I say, hey, dilute this into a usable fashion so that you can give your patient 100 milligrams or increments of 10, they look at me crazy. And it's actually hard for them to do math under stress. So what we want to impress upon you guys today is give you some things that you can do with your guys and gals to make this a little bit more safer and more comfortable for people who don't use these medications on a daily basis. What we have in front of us are a whole bunch of training vials, highly recommended. So if you want to order these things, I think they have ordering information on them. But we had these built to solve the problem of how do we get medical providers who don't administer these medications on a daily basis, how do we get them experience and confidence drawing these medications up, and how do we work through the strategies? So we have these things for you to check out. So we have fentanyl and Versed and ketamine. We didn't include a long-acting opiate analgesic on here, but that would be part of the toolbox as well. Additionally, I have we talk about hanging a 250 cc drip of ketamine. I'd like to, if we can, I'd like to explain that about why. Why 750 milligrams of ketamine in a 250 bag? Why not 500 milligrams in a liter bag? You know, why not put it in a 50 ml bag? So I want to explain this to you if we have some time. Then we have two drip sets here that are used as safety mechanisms to control, so that you don't have to do the math in the field of calculating drips. They do that stuff for you. So we want to talk logistics. We want to talk about how to actually do these things and draw them up. And we want to talk through some kind of hot button issues with ketamine and with some of these medications. So I want to pass the mic over to Dr. Calloway to talk to you guys about, he's got a great way of teaching the different dose ranges of ketamine.
So I deal with minute 1 through like hour 3, right, of pain control and trauma. And then if I'm putting someone on a drip, I'm handing them over to Glenn. First off, most of your pain management problems you're going to deal with opioids. Don't forget about opioids. Fentanyl and then longer acting ones like Dilaudid morphine are still good, right? It's all about ketamine these days, ketamine. And part of that's because now we've just started to accept that we can use ketamine. But remember, like, you still have friends in fentanyl, and then especially in prolonged field care, Dilaudid. So if you got a guy with a busted femur that you got to sit on for 8 hours, Dilaudid is an awesome drug. So I use ketamine in a couple of relevant times. One is the sort of peri-stable trauma patient, and then the other is when I need to augment because I'm giving so many narcotics that I'm starting to see the side effects of decreased respiratory rate or hypotension. And the way I break it down, and I stole part of this from someone, I'd give him credit, but I don't remember who I stole it from, but I assure you I wasn't this creative. So I look at it as the 3 Ps for ketamine dosing. So the first dose is the pain dose, second dose is a party dose, and then the third dose is the procedural dose or the put them down dose. The party dose is cool if you're in a club, you know, listening to good music, drinking Mai Tais. But in general, on the battlefield and with pain, you don't want to be in this dose. All right, so all these different protocols have different doses, and TCCC says just give 20 milligrams and you're fine. What is the pain analgesic dose of ketamine? What is it really? There's dose. What is it? 0.1 to 0.3 milligrams per kilogram. All right, so the total dose, you're absolutely right, depends on the patient. But if you understand the range, all right, that then helps you avoid this. So what's the party dose? So it's actually probably 0.3, but we'll call it 0.3 right now, but 0.3 to like 0.8 or 1 mg per kg. So technically this is 0.1 to 0.5 and that's 0.3 to 0.8, so there's an overlap, which is the kind of danger zone. And then what's the procedural dose? So yeah, so greater than a milligram per kilogram. And they'll say like 1 to 3 or 1 to 4 mg per kg. So this is the standard that I use a lot. And I can either use it by itself, or most of the data now shows that if you give some opioids first, so you give like 50 or 100 mics of fentanyl, and then you give ketamine for breakthrough, you actually get much better pain control. That's helpful because now you're not having to go on escalating doses of narcotics. So that multimodal pain control is really good. And fentanyl is a pretty stable med, doesn't drop your blood pressure a lot. So 50 to 100 mics, even in someone who's a bad trauma patient, generally isn't going to do a lot of badness to them. If you can add 20 to 30 milligrams of ketamine, then it's great. The procedure dose, so this is like, I need to do a fracture reduction. You know, occasionally dislocations. I don't usually do dislocations with ketamine because there's a little bit of myoclonus or muscle spasms, so it's a little harder. But this is like, you know, you got to debride a hand that got blown up, or you got to do a fracture reduction. So the procedure dose is 1 mg per kg, and if you give them 50 mg per kg, what happens? Yeah, they just sleep longer, right? And there are actually case reports of kids getting 100 times, 100 mg per kg of ketamine, and they're just asleep for like a day. So this is why ketamine has become so popular with what we're talking about, prolonged field care austere medicine, because the safety profile is so awesome, right? Like if I screw up and I'm under stress and I screw up the dose and I get way too much, nothing bad in general is going to happen. So if you do this dose, now what's the one sort of thing you need to mitigate? You give them a bunch of meds, you get up to this level, what happens next? After you do all your stuff, you got to come back down, right? So you got to come back through the party zone, and Glenn will talk a little bit about this, but this is where either talking to them beforehand and giving them a little brief about, hey, this is what's going to happen, what you're going to see, that'll help to some degree, but then that's where your benzodiazepine, so your Versed will come in handy. And I'll tell you what my technique is, and then I'll hand it over to Glenn to talk about drips and what his technique is. So, because I like to be able to do everything myself, so I will give 200, so I'll give JJ 200 of ketamine. I'll manipulate his femur and I'll fix it up. Once I'm done with that, then I will give 2 of Versed, because now my hands are free and now I can go up, and if there's an issue with the airway, like I can just focus on that. So my stuff's done down at the procedure, now I can focus on the airway issue on the off chance that the 2 of Versed I gave him causes him to go apneic. That's just my style. If I had, Justin sitting right next to me, I'd probably just be like, hey man, just give him some Versed and watch his airway, I'll do the procedure. So there's no right or wrong, you just need to know what your resources are. And if you're sort of a control freak like myself and you want to be able to control everything on your own, then that's why I do it that particular way. So once I've gone to this, if I've got somebody who now I'm like, okay, I got to send this dude or dudette for a while and I need to mix a drip, I don't do a lot of drips. So what I would do is I use the 500 bag, and I'm fine putting a bunch of ketamine in there and starting a ketamine drip, because I know that the side effect profile is low, and if I screw it up because I don't do it a lot, it's not that big of a deal. And then I can bump with Versed or bump with fentanyl. However, if you want to be more sophisticated, Glenn will show you easy ways to do it.
The goal here is not to go through the party phase twice. The party phase isn't any fun in the operating room when you're by yourself and you've got all these things, and my only job is to take care of his airway and kind of his mind, and his vital signs. It's not fun to go through once, let alone twice. So if you're going to go to the procedure dose, like, get there. Don't mess around and go to the party zone and then get to the procedure zone to come right back to the party zone, because that's one more time than you need to do it. For me, I work in a completely different setting than Dr. Calloway. So for me, I'm not dealing with femur. I'm not dealing, with a broken hand or a broken arm, anything like that. I'm dealing with the airway and pain management, okay? So for me, It is looking at the patient, seeing what they look like, seeing what their review is. If they've got a neck like a normal 150-pound guy and doesn't like their airways that bad, I have no problem giving them a little Versed up front. Now, if they have a neck and they look like a defensive lineman for the Carolina Panthers, I kind of back off because that may not be a situation I want to get into if I want to keep them breathing just for a sedation in terms of resetting something, okay? So you can give benzodiazepines on the front side. That's not a big deal, okay? You just have to be able to deal with any kind of situation that may arise, okay? There's nothing wrong with waiting until once you get through the procedure dose to give it here as they come back down. That's actually a great way to do it. But for me, a lot of times I give it up front just in case I don't get to the procedure dose and I'm hanging out in the party zone. I don't want them to kind of remember that. The other thing is when you start putting ketamine and Versed, Vecuronium in a bag, you need to do a couple things. A, you need to know what the drugs do, how they work, okay? If you don't know how they work, you don't have any business using them, okay? The other thing is if you're going to add, and there's some mixtures up here that you guys can look at afterward, if you're going to add Vecuronium, you better have a controlled airway, okay? Because that's the fastest way to kill somebody, all right? So if you're going to do ketamine and Versed in a bag, you know, if you opened the bag and you gave them 750 milligrams of ketamine, is it the worst thing that's going to happen? No. Is it ideal? No. If you give them 25 milligrams of Versed, they're going to stop breathing, okay? So you need to know how to deal with that, okay? So you can reverse fentanyl, you can reverse benzodiazepines, okay? You can't reverse ketamine. Ketamine's only time, all right? It's going to take its time, it'll wear off. But you need to know how to do that. It's all up to you guys how you decide to mix and use your drugs, whether you want to use 750 of ketamine in a 500 or 500 of ketamine in 500 or 250 or whatever makes sense to you. Whatever you can justify in your own mind and work out and rationalize and stamp and hold true to it so that you know how to use it, okay? But the bottom line is, with what you're giving, know how to use it and know how to take it away. I know Jim doesn't like to mix necessarily all the time, is what we were talking about. He likes to go with, if you're going to give ketamine, you can give a little bit of Versed, but let that run in if you're using a drip, and then kind of keep them separated. I would say if you don't use them very often and you're an austere condition, keep them separated. It's just easier to keep them separated because if you've got 2 or 3 things in that bag, that's 2 or 3 different things that could be causing the problem. There's one thing in the bag, you know what caused it, okay? You know how to fix it. You either go up and go down on it. You also need to, there's simple things like this, like these little dial-a-flows will save you so much time and so much effort. If you're really one of those guys that likes to count the drops in the micro dripper, go ahead. Like, who am I to get in the way of your party? You're a great mathematician, keep on. However, that thing right there will do the work for you, okay? Just remember, take fail-safes, build in checks like Jim talks about. If you're going to put it at 30 or 50 milliliters an hour, make sure you tape it so that it doesn't move, so that thing doesn't actually get twisted into a bolus thing, okay? Label it that it's a TIVA line, all that kind of stuff, so that you know what's going through it, and so that if anybody else is there to help you, they know what's going through it as well, okay? And the last thing I'll say is make everything repeatable. If you dilute a drug or if you mix it some way, mix it that way every time so that you always know what you're getting. You're not always going to get the same concentration of ketamine or Versed or fentanyl. So when you get it, make sure that when you dilute it, you find a way to dilute it the same way every time. If you want it to be 10 or 20 milligrams per kilogram of, or per cc of ketamine, make it that way every time. So you're not wondering in the middle of the night, did I just pick up the 10 or the 20, okay? Make it the same way all the time so it's repeatable and you're given the same thing that you always do, okay? Jim, you got anything to add on that?
Yeah, do you want to speak your...
Yeah, I can do that. So I think a lot of times folks wonder a little bit about ketamine and emergence delirium. So I'll tell you a little story about me, but first I will say that most of us can have we can anticipate taking care of a child downrange. I've never seen emergence delirium in children. Where that stops, nobody knows. But by and large, you're not going to have to worry about that in children. And you're going to use a lot of ketamine for procedural sedation, et cetera, for children. Now, I can tell you in the adult population, somebody like me, right, I'm 50 years old, who receives ketamine, you may experience somebody who's got emergence delirium. Is that necessarily the party zone? Could be, or it could be something a little bit more sporty than that. It could go to being combative. So I'll tell you a story about what happened to me about 2 months ago. I subjected myself as a patient to a low-dose ketamine infusion to evaluate a program to treat PTSD, right? And I went through this this protocol for a local physician who wants to offer this near Fort Bragg. And I got about 0.5 milligram per kilo, so I got 40 milligrams over 45 minutes. And I will tell you that after the fact, my arthritis was significantly improved for about 2 weeks, and my affect was, I was awesome. I felt great. I did not have any of those issues that some people would say, hypervigilance or anything like that. And yes, I do have a diagnosis of PTSD. I'm not ashamed of that because I felt like I earned it through 10 deployments. So this was the deal, though, with ketamine in getting the infusion. If any of you, and I've told this story now 3 times, if any of you have read the Edgar Allan Poe short story, The Cask of Amontillado, where the main character was being buried alive in a very dark place, that's what it was like. And I intentionally put myself through this without Versed because I wanted to remember so I could tell this story so that I could properly evaluate their program at this local facility. So it was disconcerting, and I'll probably never ever do that again without Versed. In fact, I know I'll never ever do that without Versed. But the data that supports its use, its low-dose use for PTSD is quite significant, and is actually growing. Hopefully someday we'll have enough data so that we can take away its off-label use and actually use it on-label use. So that's about all I got. Unless you have any questions about ketamine. I've been using it for like the last 25 years, so it's great stuff.
You've been administering it to patients for a while.
Yes, I've been administering it. Only used it once.
Is it, to you guys, the anesthetist, is it impractical, impossible, or just beyond those days of trying to set up a TIVA drip and actually sitting there and counting the drips and not having any pump or drip counter? Are those days over?
Yeah, so if I get 60 drop tubing, I'll use 60 drop tubing, which is mini drip tubing, and which is, you know, if I want a 50 mil per hour drip, I count 50 drops in a minute. So yes, we do that. But by and large, most of us, honestly, if you're asking me how do you really practice, I practice in a titrate to effect mode anyways. But for those of you that aren't really yet comfortable or clinically to do that, then it can be done. You just count the drips. Preferably, you're going to be able to do some math. But try to find the mini drip 60 drop per mil tubing. And I think for our population in the soft community, a 50 mil per hour rate in a ketamine infusion is probably more than adequate. So what does ketamine do for us? So it's a dissociative anesthetic. It can be a complete anesthetic. So it'll provide analgesia, right? It'll provide anything else? Does it provide anesthesia? No. Dissociative anesthesia. It's a dissociative. So it will turn off basically the thalamus. It's like you're done. You're not going to really respond in a high enough dose. It does not provide muscle relaxation though. Okay, so when I mean muscle relaxation, like Dave was talking about to reduce a fracture or anything, it's not going to do that. So you're going to have to find other methods. So maybe a Valium like you would use in other situations. But the phenomenon of emergence delirium is real, but it's not something you can't deal with or mitigate. Just when you're doing a ketamine infusion or drip or a total IV anesthetic using ketamine, just have the things available to be able to deal with sequelae. Make air go in and out, blood go round and round, and to be able to treat these things.
All right, thanks, Jim. Okay, so when we were in the conference room earlier, I talked about the boxing analogy, and that if you just hit the heavy bag all the time, it's probably not going to go well in a fight. You have to do all the different components of boxing, and it's a really difficult thing to do. And the best people, that's what they do for a living, right? It's a really complicated thing. So one of the tools that we use to put this skill set in the hands of a medic who doesn't push medications every day is we kind of wargame this thing. So one of the key components of the wargame is subject matter expertise, people that actually do this for a living and are comfortable with these medications. So you could go to the OR with Glenn. You can go and hang out in the emergency department with Dave, and hopefully you get those ketamine cases, right? But there's another way you can do this that's very low cost, and that's just to wargame this. So what I'm looking for here is not to put anyone on the spot. I'm just looking for different opinions, because we're going to see there's a whole bunch of different ways to solve this problem. but it's good to see in the room how people would handle these situations. So here we go. We have a patient in North Africa, and who's injured, and we can't leave till tomorrow. Okay, so this particular patient, they were running a mortar range for local, for the host nation, and the base plate jumped, and the guy degloved his whole hand. So he's got this horrific hand wound. Here's his vital signs: heart rate of 110, respiration is 22, BP 140/90, satin at 99%, pain 10 out of 10. Okay, a sandstorm came through. We can't leave. We got to handle this right now. So here's our toolbox in front of us. So we've got ketamine, we've got Versed, we've got fentanyl, and let's just throw a long-acting analgesic. We'll throw in Dilaudid or morphine in there. So we've got this toolbox. We could hang a sedation drip. So initially, you got the guy standing there screaming about his hand. He thinks he lost his hand, and we got to take care of this. So let's just throw some options out there. What do we want to do? And this is how we run the exercise. So you got your SMEs up here, and just throw out some options.
So with BP already at 140, probably start with 5 milligrams of morphine and 5 milligrams of Versed just on the BP.
How are you going to give it?
IV.
So think of, okay, so this is a logistics drill. Because you guys are smart, you know the method, but a logistics drill. So, okay, so one option is start an IV and then give 5 of morphine and 5 of?
An IV piggyback. Just start the drip and do maybe a
drip of what?
Flush.
Sorry,
just a regular normal saline.
Okay, so start an IV, start normal saline, give 5 of IV morphine, and what, you said something else?
5 of IV Versed.
5 of IV Versed, okay?
All right, so that's who wants to throw a different option out there?
So if he's screaming in pain, you can give him like IM to kind of calm him down before you get the IV. If he's, fighting you in pain, are you really going to be able to get the IV on him?
Okay, so give him what, you think?
You do like ketamine, 50 milligrams. Like
Okay, so 50 milligrams of ketamine.
50 milligrams IN or IM?
IM.
Intramuscular.
Yeah.
Okay.
Or I guess IM.
Okay,
Well, so both options,
this is good. These are drastically different approaches. What else?
so
Who else has got something? Who thinks who would handle it totally? I would handle it totally different, but I'm not.
Yeah, roll.
Sir.
But
Yeah, what-
I looked in
yeah.
Afghanistan for something comparable, 3 milligrams of Versed IM, followed by 100 milligrams of ketamine IM. You wait, it's about 8 minutes, checks in, and then you can start your IV and do the rest of it.
Okay, so 3 of Versed and 100 of ketamine IM. Okay, anybody else? Somebody?
I was going for nerve block, but
Okay.
you didn't put
That's
the
coming.
local up in.
Okay.
If you can get them.
Okay, using this toolbox, anybody else? Something different? Okay.
with IM.
Okay, so we've got a different approach
With
here.
IM or IM.
So how much fentanyl do you think?
On him?
Yep.
How big of a boy is he?
Everybody's 100
100
kilograms.
All
kilos.
right, just give him
The
100.
new America.
Okay, so 100 micrograms of
Tell the Army
fentanyl.
that.
How are you gonna give it?
That, start the line and go IV on that fentanyl.
Okay, so this is just the start of this drill. So what we do at this point is we go and we talk about all the different options that people throw out there and the pros and cons of these things. I don't know that any of them are flat out wrong, but what we can do as a group is we can go through and figure out what might be a better or best option here for pain control in this guy. Yeah, so
That's the future, maybe we'll talk about that later.
yeah, so this is where you guys weigh in and you talk about some pros and cons of these things.
So the one other thing I'd add on there, so 2 other things I'd add on there. From this toolkit, so intranasal fentanyl, right, is really good. We use it in kids all the time. And then not on here, but what else do you guys care for fentanyl? It's pretty common. Yeah, right, exactly. So remember, so multimodal and then multiple different problems you're trying to solve. So initially, what do you want? This guy's yelling and screaming in front of you, he's your buddy. What do you want to do immediately? You want immediate pain control as fast as you can, right? And you want to do it in a way that keeps him stable. Then after he's sort of chilled out, and it's not pain gone, but pain controlled, then you start looking into okay, now I have to deal with his hand, and so I'm going to have to do some stuff. So now that's a different strategy, right? So what is the fastest way to get pain control on board, do you think? Probably, so intranasal fentanyl, I would say, is probably one of the fastest. Transmucosal fentanyl, pretty fast. Intramuscular is a good option, but probably takes a little longer. I usually use intramuscular stuff on people who I either can't get an IV on. It's usually who I can't get an IV on. Okay. Morphine and Versed IV, probably a good option for the second part of it, which is now I got this dude, his pain's kind of chilled out, but now I'm gonna have to like mess around with his hand. I'm gonna have to irrigate and that kind of stuff. So, a combination of narcotic plus a benzo, probably a decent option. Nerve block, definitely an awesome option. And then, the IM ketamine and Versed, the times that I use that kind of cocktail, so that's also great, but I'll use that on like, if I've got a bunch of people that I gotta deal with and I'm trying to figure out, so I'm like, this guy, just a hand. He's in a lot of pain. Like I can probably give him that and then come back and check on him in 10 minutes or have someone watching him. But otherwise, I think that the IN is a pretty good option for the initial.
Yeah, until you can get an IV, it'll be the fastest route. None of these are wrong. It depends on what you've got and how fast you can get it. If you're looking for the fastest thing, IN. If you already have an IV, then just stick on the IV route. I think that's where we're all going to.
Maybe this is the one that's probably the most questionable.
So how many of you have used intranasal ketamine? Yeah, what were your results? You're shaking your head like, please never again. Yours?
The problem in the dusty environment to get something IV, IN, is that he's working outside, there's dust outside, and if you want to get it intramucosal, it doesn't work.
Okay, and same thing kind of deal? Well, that's a variation in how well it works, how fast it works, if it really works. I've seen people use up to 300 milligrams of intranasal fentanyl ketamine, and finally switch over to IV just because,
you have to have a willing participant.
And you have to have a willing participant. So for this guy, I would probably say to him, hey, look, it hurts. You're getting an IV, and then everything's going to attack you much faster. Okay. For me myself, I like ketamine, but this guy's walking, he's talking, he's breathing, he's in a lot of pain. For me, I would tend to go down the fentanyl side, get his pain under control, and then if I need to hit him with a little bit of ketamine, I can, and a little bit of Versed to kind of calm him out. But the first thing I want to do is get an IV and get fentanyl on board him. And that's me coming from where I work and what works for me. It doesn't make it right, it just makes it different. Okay, ketamine's fine, but once again, as we talked about earlier, you've got to be able to go from that pain dose, and for this, you don't necessarily need to get to the party dose. You may be able to wrap this thing and inspect it without getting to the procedure dose.
One thing about this, if you're going to think about a nerve block at some point, and this is forthcoming, you've got to set the conditions that the nerve block is actually going to be successful. So therefore, you need a cooperative patient, like we were talking about. A person who's in a severe amount of pain is not going to cooperate while you're trying to probe around in their neck to try to put or their axilla to do a nerve block. So there's going to be a primary mode and then a secondary mode of analgesia, which could segue down into a nerve block. But primarily, that's not going to be the thing that we're going to do. We're going to get the pain under control so that he's now a manageable patient, so he can be still. So if we do an ultrasound-guided nerve block, we'll actually have a reasonable chance of success.
So giving the guy an active participation in his care helps with feeling control and helps with pain control. So given the transmucosal fentanyl, hey man, here you go, put this in, I'm going to get an IV and I'm going to give you some good stuff. Boom, he's thinking about it. That's going to start kicking in. Tell him it's going to start kicking in a minute. All right. So now they know, right? Because part of pain is fear. All pain is a chemical reaction in your body, right? And we've decided to interpret it as something bad. So if they know, hey, this is going to go away in a minute and I've got stuff on, so that's helpful. That chills them out while you're getting the IV. And then I agree. So this is one of those ones where ketamine's awesome, but we know that ketamine's way more effective if you give opioids first. So if you're giving 100 micrograms of fentanyl and then they're still having breakthrough pain, that's when giving 20 milligrams of ketamine IV is a super effective adjunct. All right, so that's a great option. All right, so it's phase 2.
Okay, so we need to wrap up the group, but we just scratched the surface on this. We could talk, we could just talk from the anesthesia point of view for another hour on these options and the good points and the bad points. We could just talk the emergency medicine point of view. But I want to emphasize, these things up here, these are safety measures, labeling your medications, and we didn't really get into this logistic piece. If you want to mess with this stuff, it'll be here. Why did we say 750 milligrams in a 250 bag? Why did we do that? We got to break the group. So if you want to come back and chat about that, that stuff will be here. And then the last thing I want to talk about, we touched on it briefly, but this is the takeaway I'd like to remind you guys of, is intranasal ketamine, we start talking about it, is that everyone is talking ketamine about everything, but in an unsecure environment where your patient could have a horrific party dose experience where the day is not won and we might not be secure, we want to stay out of that range. And when it's dark and scary and we want our patient to continue talking with us, and when we want to give a medication that's going to last 45 to 60 minutes and not 15 minutes, the mainstay has been opiate analgesia. So I would just remind everybody that we have a very good pain control option that's been out there, and it's safe, and fentanyl is not it's not going to mess with your blood pressure. So we tend to seek fancier options to attacking pain when this is a really good option. So I would just remind everybody that, and when you go back home, just bring that back up and ask your guys, are you seeking a fancy option, or are you seeking a tried and true option where the patient's still talking to you, maintaining their airway, and can walk? These are important things to consider.
All right, well, that wraps up this SOMA-sponsored episode. There will be plenty more on the way, so stay tuned.